Hello, everyone, and good morning. Thank you very much for your time in joining us today. I'm pretty chuffed that we have Professor Dom Rowe here to talk to us today. Dom is very well known to everyone, but also, obviously our leading expert in research, MND research, the explosion in understanding genomics and how it relates to MND, and also some of the latest developments in drugs such as Tofersen. Tofersen, we have known in Australia as Tofersen, but it's actually recently being sold as Qalsody. So I'm going to work very hard to talk about it as Qalsody from now on. But before we begin, I would like to acknowledge and pay my respects to the Ngunnawal people, the people on whose land I'm joining the meeting today. I'd like to extend this respect to all Aboriginal and Torres Strait Islander people in attendance today, whose cultures are among the oldest cultures continuing in human history. If you'd like to share an acknowledgement of where you're from and where you're joining from today, please do so in the chat. We will have time for questions from the group at the end of this presentation. So I'd like to encourage you, if you've got questions for Dom, please pop them in the chat and we will throw to them. But without further ado, Dominic Rowe. Dom, you have been working at Macquarie since 2007, the youngest professor of neurology in Australia, absolutely instrumental in establishing the Macquarie Health and Neurology Clinic. And I don't know what thousands of people you've cared for with MND and, of course, Parkinson's as well. So, Dom, delighted to have you here today. Welcome.
Thanks, Claire. It's lovely to be here.
Dom, I'm going to throw straight in. What is SOD1 and what is Qalsody going to do for SOD1 and people with MND?
So in the very early 90s, the first genetic cause for motor neuron disease was identified. So in work that also was done by David Williams and the team also in Perth, David Williams from Newcastle and Perth were instrumental in this international effort to identify SOD1 as a cause of inherited motor neuron disease. So if we look at all people with motor neuron disease, around about 10% is caused by a faulty gene and 90% is sporadic. And over the last 30-odd years, we've made tremendous inroads into the genetic causes of motor neuron disease, such that there are more than 40 genes that cause genetic motor neuron disease that's passed down within a family. When we look at our sporadic patients or seemingly sporadic patients, we do find in a very small percentage that there's a faulty gene. So we systematically study everyone who comes through the clinic for faulty genes, and sometimes we pick them up. So the first gene that was identified was SOD1, and this is a detoxification enzyme that is in every cell in our body, and it's incredibly well preserved throughout the whole of evolution. So even E. coli in your gut, the little bacteria in your gut, this enzyme SOD1 is identical. And in fact, it was in the 1960s that a very famous microbiologist by the name of Erwin Friedrich identified an isolated SOD1 out of E. coli. So mutations in SOD1 cause damage to motor neurons. And that's thought to be what's called toxic gain of function. And there are more than 200 mutations in SOD1 that have been identified in families. And most of those are in the expressed parts of the gene, what are called exons in the gene. So the dominant genotypes here in Australia are V149G and I114T. And these are different to the genotypes that you might read about in the literature or on the internet, where A5V and G93A are the dominant genotypes in, say, North America. So most of these faulty misspellings in the SOD1 gene produce this toxic gain of function. And very early on, from the mid-1990s, Bob Brown at Harvard started to work on down-regulating this gene to see whether, first of all, in vitro and then in vivo, he could prolong survival for SOD1 in SOD1 models. So fast forward 30 years and the FDA approved in 2023 Tofersen on the basis of suppression of neurofilament. And this was on the VALOR study. So the VALOR study was an international multi-site study looking at people with 12 different genotypes. So they picked pretty much the worst genotypes in SOD1 to see whether this therapy worked. And they were able to demonstrate suppression of neurofilament. But the VALOR study didn't reach significant endpoint over 6 months to demonstrate a slowing of the progression of ALS-FRSR for many reasons. And I think that's because they pretty much picked the worst genotypes in SOD1, and also probably the study period was too short at 6 months. So the VALOR study has turned into the ATLAS study, and here at Macquarie, we're the only Australian site for the ATLAS study. So the ATLAS study has recruited people who carry a faulty gene but don't have motor neuron disease. So they carry a fault in SOD1, but they don't have motor neuron disease. And we watched these people with blood tests every month to see whether we could detect either an elevation of neurofilament in their blood or if they developed symptoms while they were being observed. And then they started therapy in a placebo-controlled fashion to see whether we could delay the onset or dramatically slow the progression. You've got to remember that by the time you're weak with motor neuron disease, you've lost 70% of the cells that are talking to a muscle. So the earlier you can start therapy, the better. And so that ATLAS study is now in what's called Part B and has finished recruiting. And the whole neurology fraternity and the MND community are watching that study with bated breath.
And so that study's looking more broadly at, so what's the relationship between that study? Because obviously here in Australia, the TGA's just approved Qalsody or Tofersen in Australia.
Yeah, so that's for symptomatic motor neuron disease. So we can't treat people with Tofersen if they just have an elevated neurofilament level. So there's no point if you have a faulty gene for just doing measurements of your neurofilament, until it becomes a proven therapy for pre-symptomatic motor neuron disease, which is, may well happen. Knowing your neurofilament level doesn't really help you if you're clinically normal. That's the most important thing. So, for the ATLAS study, of which we have 2 people on the investigational arm, and we were the 3rd highest recruiting site globally into the ATLAS study, because we're very fortunate here at Macquarie in that we look after 143 families now with genetic forms of motor neuron disease.
So what are you seeing from Tofersen, from Qalsody? What's actually happening to patients who are receiving this treatment?
Well, we're nearly 6 years in with our longest standing patient, and the expanded access scheme enabled people regardless of genotype. So the VALOR study had very restricted number of gene abnormalities in SOD1 that enabled you to be recruited on the study. But in the expanded access program, it's not dependent on the mutation that you've got in SOD1, which was a very, very generous and appropriate move by Biogen to enable us to get our hands on this therapy. And so we have longitudinal data on many patients that we've been treating over the last 6 years that demonstrate that in SOD1 related motor neuron disease, for some patients, we can dramatically slow their motor neuron disease.
How much does it slow by?
Well, I think that's dependent on variables that we don't yet understand. So some mutations are, dreadful. It's like a huge firestorm of MND, and Tofersen doesn't really help that. And in addition, how the tofersen is administered is by lumbar puncture. So, and we know that there's a gradient of penetration of this therapy up the spinal cord. So if you have bulbar onset motor neurone disease, in our experience and the experience around the world, so if it's bulbar onset motor neurone disease related to SOD1, then tofersen's effect is modest.
And so what does this mean for people in Australia? So there's probably, maybe 100 across the country who Tofersen Qalsody's appropriate for. What does this mean?
The significance of tofersen should not be underestimated. And in fact, it's a therapy that, to be frank, Claire, I never thought I'd see in my career. So to have not one but two genomic therapies for SOD1, because there is another trial therapy that's being assessed for SOD1, and so to have two SOD1 specific therapies is really, look, I'm not a religious person, but it's miraculous.
And it goes to this hypothesis that if we can find out the cause, if we can find these genes, then we can speed up research into treatments on those genes. The more we know about the disease, the more we can develop treatments. And
exactly, because tofersen is SOD1 specific, and the mechanism by which it works. So tofersen is what's called an antisense oligonucleotide. So you've got to say that 3 times quickly, antisense oligonucleotide. And so what happens is that this therapy is given in the spinal fluid, and it percolates through the spinal cord, through the fluid, and it goes into all the cells, and it suppresses the RNA that is produced by SOD1 in all the cells. Now, it suppresses it by around about 10%, the native expression of SOD1. So and the antisense therapy is the first proof of concept that if you can suppress toxic gain of function, you can change the outcome for this disease. And similarly, for all the other all the other gene abnormalities that cause motor neurone disease, we need gene-specific therapies, because we can't use tofersen, for example, the commonest genetic abnormality, which is C9orf72. And C9orf72 is proving to be quite an elusive target. But again, there are trials coming down the pipeline that are actually just about starting in multiple sites in Australia to try and suppress C9orf72. So, we need gene-specific therapies to dramatically slow the progression of the disease.
And so we need one for each of the 40 genes we've found so far. We just need to work.
Perhaps. There might be common pathways that, so for example, everyone would have heard of this protein TDP43. And so this TDP43 misaggregation occurs in the cytoplasm of neurons that are sick with motor neurone disease. But TDP43 isn't part of the mechanism of SOD1 motor neurone disease. So you don't have TDP43 aggregates in SOD1 or in FUS. So, there are multiple groups around the world that are trying to attack TDP43 aggregation as the pathway to nerve cells getting sick. So there may be common elements. If we can take a leaf out of oncology, for example, so, there's therapies for, say, melanoma. So 15 years ago, if you had metastatic melanoma, your 5-year survival was 1%. It's now 50%. Why is that? It's because we understand the cellular mechanisms that are involved in the melanoma cells metastasizing and continuing to grow. So a whole group of therapies called BRAF inhibitors were developed that dramatically changes people's melanoma if they have a mutation in BRAF. But if they don't have a mutation in BRAF, BRAF inhibitors don't work. But there are other therapies like PD-1 inhibitors that are used in multiple forms of cancer that have the ability to change the influence in melanoma. So often these therapies are synergistic, and adding them together, 1 + 1 is more than 2.
Have we tried Tofersen on people who don't have the gene? Do we know what happens, if you don't have SOD1?
There have been some studies by Angela Genge in North America, and she's looking at misfolded SOD1. So they've developed therapies so some patients, when they look in your blood in sporadic motor neuron disease, there's misfolded SOD1. And so Angela is working on developing a therapeutic. But Tofersen, if you give Tofersen to someone with a different gene abnormality, it doesn't work. And if you give Tofersen to someone with sporadic motor neuron disease, there's no reason to suspect that that will work.
Yeah, makes sense. What's a folded gene?
Misfolded. So when there's a school of thought in sporadic motor neuron disease that continues to be very interested in how these proteins change folding, and then, coming back to one of my dear friends and colleagues, Justin Yerbury's concept of this proteostasis, that misfolded protein ends up clogging up the garbage disposal of neurons. And these cells are incredibly sensitive. The metabolic demand on our motor neurons is really quite extraordinary. And these cells were formed when you were made as an embryo. So, and we don't get new ones. We can't make new ones.
Fascinating. Going back to Qalsody, to Tofersen, you said it's a spinal infusion. How long does that take? What does that look like? Do people in regional and remote areas, can they access that? Is it only metro MND clinics? Talk us through the actual administration of the medicine.
Well, we have patients that come from many miles away to get Tofersen for one reason or another. And there's no reason now that any site, for any site to not offer Tofersen. Now, logistically, it is tricky, but it's not impossible. And when you consider the alternative, logistics are the least of our problem. So what we do is, first of all, we have to get what's called TGA Category A approval. So we make an application with the genotype to the TGA for approval to use this therapy, because up until recently it wasn't an approved therapy in Australia. So then what we do is order the product from Clinigen, and that arrives. So you've got to be a registered site. You've got to have a pharmacy that can catch it and store it. We then make sure that the patients have no complicating factor that you can't do a lumbar puncture. So we make sure that there's pretty much everyone with motor neuron disease will have had a whole spine MRI scan. But if there's, for example, a spinal problem that the Tofersen that you're injecting down the bottom of the spine can't percolate up, then you need to know about that. So we do safety bloods and we do a scan, and then with informed consent, we talk about using this Tofersen if you have an SOD1 gene abnormality. And initially it's day 1, day 15, day 29. So it's 3 loading doses, and it's done by lumbar puncture. In our site, we do that with CT guidance. So it's done with local anesthetic. So it feels like that. It doesn't hurt. Well, it doesn't hurt me, but it doesn't hurt. And it seriously doesn't hurt. It feels like someone's just pushing in your back, which is why we do it under CT guidance by one of 2 neuroradiologists. And then they take CSF out and they put 15 mils back in. We measure the pressure, and we measure the CSF constituents, because one of the side effects of Tofersen is inflammation in the lining of the brain, and that can elevate the pressure inside your head. So then patients often just lie flat for about an hour or so, and then they're up and around. So we don't have, so some of our patients are up over 80 Tofersen injections. So you can imagine that if that's not managed to the best of our ability, so it's we have the booking, we know there's no hold up, there's no variable around whether there's a bed available or not. Everything is booked in radiology. It's done by the same person, by the same team. Otherwise, you could imagine if you were fronting up for a lumbar puncture every 3 or 4 weeks and you didn't know who was going to be sticking a needle in your back, it could become quite rapidly quite traumatic. So, you know, we try and make sure that the experience for our patients is as seamless as possible. So there will be difference. Some units don't use image guidance. We're very fortunate that we do, and because that makes sure we know 100% it's a single pass and that the therapy is actually in the right place. So other units don't do that. They have much more confidence in being able to do lumbar puncture and intrathecal infusion without CT guidance. Then depending on exactly what's going on with the patients, we have them booked in, so before they go home they know their next day, and in fact we usually book about 6 months in advance. It means that there's quite a few logistic issues making sure that we have enough Tofersen ordered, and that will change with the PBAC and the TGA approval. There will be a few little logistic issues that, you know, there's always wrinkles when you start a new process.
Of course. You mentioned side effects. What are the side effects of Qalsody, of Tofersen?
Well, there's the side effects related to the procedure, and there's the side effects related to the medicine. So, as I said, we've been doing this for nearly 6 years. We have had, I think, 1 patient with a very tiny post-lumbar puncture headache. So we use special needles. Like I said, we use X-ray control, and we define and control as many of the variables as possible. We do safety bloods before every single lumbar puncture. So we have to see that patients' clotting is normal, that their platelets are normal, that there's nothing else going on. And then there's the side effects of the Tofersen. So in the studies, they do report backache, they do report nerve root irritation, so people can get numbness and pins and needles in their legs. And then some people can get headache, which is a manifestation of chronic inflammation. So, like I said, some of our patients have had 80 injections, and I think when Tofersen was first mooted, I don't think that they were thinking about this as people having 80 injections of the same therapy. But so that's pretty much it in our hands. There are no systemic effects of Tofersen at all. There's theoretical risks with breastfeeding and pregnancy, but I think those risks are theoretical. There's no interaction with riluzole, and there doesn't appear to be any crosstalk with any other cells or enzymes at all in long-standing use of Tofersen. So it's very, very specific.
Fantastic. I mean, this is a game changer for us all, really, isn't it? This is the promise that there will be more medicines and more hope, and that we can treat MND.
Well, the first path through the jungle is always the hardest. And, you know, it took 30-odd years from genetic discovery, 30-odd years from genetic discovery to actually having the therapy in the clinic as a routine. So the next path through the jungle for the next genotypes is going to take a fraction of that time. And like I said, there are other mechanisms. So antisense therapy is while it's very specific for SOD1, it is a big strategy. So it's actually coating the whole of your nervous system with this antisense RNA to try and suppress this one protein. And you know, there are multiple approaches to try and get better suppression and to be more specific, less crosstalk.
I can see a lot of questions popping up in the chat. Dom, if it's okay with you, I'm just going to run through the questions and throw to you for each one. The first one is from Julie. Will we reach a point in the future where it can be delivered orally rather than via the lumbar puncture?
I have no doubt, Julie.
Yeah.
Either intravenous or orally. There are multiple challenges. So RNA is a very fragile molecule, and exposing it to gastric contents, so your pH in your stomach is 2, and so it pretty much destroys most things, and that's the point of your stomach. So, but there are many strategies that enable RNA to be protected and then can be delivered to the central nervous system. Whether that will happen quickly, I don't know.
Could you do it as a blood infusion rather than a spine infusion?
Yeah, there are approaches that we have. The challenge of a blood infusion is that we have this incredibly amazing barrier called the blood-brain barrier. And so we need to have the RNA therapy sort of put inside a Trojan horse that sneaks past through the blood-brain barrier and gets into the brain. And there are many teams around the world working on that right now.
Fantastic. There will be a lot more progress then.
Well, there's a trial going on in Britain right now in a different disease called frontotemporal dementia. That's an intravenous delivery of genomic therapy into the brain.
Fascinating. We might have you back to talk about that one next. I've got another question from Adam. Adam says he's been on Tofersen now for 2 years and certainly feel progression has plateaued and potentially some improvement. Adam comments that Rick Bedlack had a webinar last week that mentioned 50% of patients have plateaued and 25% have improved. Does that feel right to you? People are improving as well as plateauing or slowing the progression?
No, I haven't witnessed with Tofersen, I haven't witnessed anyone getting better.
Yeah, there's a woman in Canada, I think. Anyway, Adam also has another question on if people are taking Tofersen, do they also need to still take riluzole?
Well, it doesn't hurt. It's quite safe to take them together. Riluzole. So I've often likened riluzole as sitting in, you know, a 10-ton truck traveling at 100 kilometers an hour, and it's like putting the handbrake on a little bit. So it does help to slow. And there are people who respond to riluzole and people who don't respond to riluzole, and we haven't yet worked out those pharmacogenomics, even though, you know, riluzole's been around for 30 years. I think it's highly unlikely that the people who own riluzole are going to invest a lot of money in understanding why some people respond and some people don't. But I would certainly recommend staying on your riluzole.
Yeah, okay, fantastic. I've got one that says, given a specific SOD1 variant, what would you need to change for you to recommend starting Tofersen, and how would you recognise that point as early as possible?
Well, there's this concept so if you have a faulty gene, you're at risk for motor neuron disease. And depending on what the gene is, you may or may not get motor neuron disease. Now, some genotypes of SOD1 have complete penetrance. So you heard me mention A5V before, which is a genotype that's very common in Indigenous North American population. And if you are unlucky enough to inherit A5V, then by the age of 50, it's pretty much 100% penetrant. Some other genotypes are much more indolent. For example, there's a genotype called D91A. And for some people with D91A, it can look like common or garden motor neuron disease, but other people with D91A have this incredibly slow progression. And so whether or not to use Tofersen, I think, is determined clinically. So if you don't have manifest weakness, you wouldn't pass muster to get approval for Tofersen. And so it would have to be manifest weakness. But the person with the gene abnormality says, well, I've got symptoms, I've got twitching, I've got cramp, I've got reduced endurance. But the rule is that we can't actually give it to people unless they've got, definable weakness.
Got another question here on government processes, essentially. What does the TGA approval mean? What's the implication on the cost of Tofersen? Could you give us Medicine Regulation 101 in Australia, please?
Okay, well, we have this federal body called the TGA, and when a company like Biogen has a product that they wish to bring into market, they first of all need to prove that it works. So they spend a lot of time and a lot of money making this application with a dossier of all the information, including preclinical efficacy, the VALOR study, the ongoing ATLAS study, but also the huge reams of information about toxicology and safety. So then the TGA at arm's length has an expert panel and they assess the application as to whether it should be approved or not. So, and that approval process is not necessarily predictable. And there are examples of drugs getting approved in Australia that might not pass muster if they were really studied intensively. And a good example is that the difference of opinion around edaravone. So the FDA has approved edaravone, TGA has approved edaravone, but the European Medicines has not. They do not think. So if you're in Europe, edaravone is not a therapy that one can do as an approved treatment for motor neuron disease. So what happens with TGA approval is then the company makes an application to the Pharmaceutical Benefits Advisory Committee around reimbursement. So if as a Medicare item, for example, on the PBS. So these genomic therapies are incredibly expensive. And so the PBAC has to decide whether the Australian taxpayer is getting bang for its buck around Tofersen for SOD1 motor neuron disease. And I appeared in front of the PBAC and showed them our data.
So we need the research to be done to develop the medicine. Then we need the TGA, the Therapeutic Goods Administration, to approve the medicine in Australia. And then we need PBAC to approve the PBS subsidy. And that's kind of the process to get a medicine to market and widely used and subsidised in Australia.
Yeah, and again, there are bigger political concerns around that. So we're very fortunate in Australia with our pharmaceutical benefits scheme in that they drive a very hard bargain with pharma to drive the price down as much as possible. And that's, why some countries look at our PBS with envy, and some countries look at our PBS and want to destroy it because it affects their companies that make profit. So sometimes, you know, companies make a decision not to market drugs in Australia because they make an argument that the market is too small. You know, we're 1% of the world's population, and the PBAC drives a hard bargain, which becomes then the price point in the field. And so all the other countries go, well, you're selling it to Australia at this, why aren't you selling it to us for the same?
Very interesting. There's also timelines. I've heard it be 400 days or more to get medicine, once it's proven to have, you know, sufficient efficacy, approved by the TGA. So slow, expensive, and a difficult negotiation with the government.
Well, it depends on the complexity of the therapeutic, and it also depends on how convincing the data are. So if you had data that was incredibly convincing with a really safe therapy, then that would get streamlined.
Okay, interesting.
They're all about safety, the TGA, and rightly so.
Yeah, yeah. Got a question here from Phil, who's wondering what we're learning from SOD1. Will this also give hope to those with sporadic MND? Could these breakthroughs eventually unlock treatments for the wider MND community as well? We don't know. We still don't know.
Phil, thank you. It's a topic that is my concern is that we've had this tremendous advance in genomic therapies for genetic motor neuron disease. My concern is that we've taken our eye off the ball and we're not thinking enough about cause of sporadic motor neuron disease and mechanisms in sporadic motor neuron disease. There's no reason to think why a genomic therapy would even be would be appropriate in sporadic motor neuron disease. So we've got to stop thinking about this as one disease. It's not one disease. Got to call it motor neuron diseases. And it's that complexity that will yield insight into mechanism that will ultimately translate into therapies for everyone with motor neuron disease, genetic or not.
Fantastic. Question from Nitesh on bulbar. You mentioned live onset compared to bulbar. Can you please explain how many current patients in Australia are suffering from bulbar? What do we know about the phenotypes for MND?
Okay, so in our clinic, around about 25%, give or take, maybe 1 percentage point either side of bulbar onset. So bulbar onset motor neuron disease tends to be more female predominant for reasons that we don't understand. And again, that comes back to trying to think about site of onset as a clue, which I think we perhaps aren't doing enough of. But bulbar onset, because it affects your speech, swallowing, and breathing early, those survival elements immediately come into play. Now, Tofersen therapy is delivered in the lumbar intrathecal space. And, you know, that's a long way away from here to here. Well, in me, not so far, but in some people, much further. So, and we know that these therapies, there's a gradient from infusion. And so the field in Tofersen in antisense therapy, I think needs to rethink about whether there are other ways of delivering the therapy such that people with bulbar motor neuron disease who perhaps need it the most have efficacy from the therapy.
And what about the other phenotypes or subtypes? What do we know about the prevalence of them?
Well, in the last 6 years, certainly if we have lower limb onset of motor neuron disease, those patients tend to do the best. So in following our patients, but again, it comes back to the genotype too, because I often liken these therapies as like a firefighting unit. So we've got a firefighting unit with 10,000 litres of water. And if you've got a small grass fire and your motor neuron disease is not aggressive, then you can probably slow it down. If you're dealing with a 10,000 hectare inferno, your one fire engine with 10,000 litres of water is not going to do much. So, you know, again, picking apart that biology of why some forms of SOD1 motor neuron disease are incredibly aggressive and others are much more indolent, again, that's avenue for study so that we can perhaps employ the factors that make an SOD1 motor neuron disease indolent. Perhaps we can actually plug and play those on people who are aggressive.
That is something we'll hope for in the future. I've got another one on SOD1. Is there any test that provides information as to how rapid the progression of the disease will be for each individual once the symptoms are evident? And is this consistent with families where SOD1 mutation is present, or will it always be varied?
It's it depends on the genotype. Again, it's a great question. So many years ago, following the discussion of the discovery of SOD1, the literature used to say that genotype confers phenotype. So which mutation you have determines age at onset and how rapidly the disease progresses. We know that that's not the case. And, you know, in one of our big pedigrees with V149G, we've had patients who've become symptomatic at the age of 19, tragically.
Yeah.
And we've had patients who become symptomatic at 72 in the same family with the same mutation. So there are clearly modifying factors, both genetic and perhaps environmental. So that's, again, the concept of epigenetics. Can we influence genetic manifestations of a disease by what's going on in the environment? And that's, again, extremely complex, but, you know, there's a lot of work that's already done on that, including by the team here at Macquarie on epigenetics and methylation of genes to work out whether that's relevant to gene expression or not. So is there a cut and paste? Unfortunately, no. So unfortunately or fortunately, we have some people with SOD1 mutations that I've been looking after for 10, 15, 20 years who've moved very, very slowly, and we haven't even needed to reach for things like Tofersen. And then we have other patients who, you know, you may have heard me comment that the quickest person that I've seen die from motor neuron disease was 8 weeks in a 38-year-old mother of 2. And she had a very rare mutation in SOD1 called cis6G gly. So cysteine changing to glycine at position 6. So that's what the numbers mean.
8 weeks.
8 weeks.
Makes me stop every time I think of that. I'm going to go to another question from Adam. Adam's talking about, or we've got a question about side effects. He's on Tofersen, saying that recent side effects have been bad headaches that hit hard for 60 seconds coupled with dizziness, and strange that sometimes getting out of a vehicle or to sit and stand and his blood pressure is changing or not changing properly. Does this sound like side effects of Tofersen?
It may be related to the lumbar puncture, Adam. You might be having a thing called post-lumbar puncture syndrome or post-lumbar puncture headache. It's where the pressure inside your head is too low and it feels like your brain's hanging off its roots. So, and if the headache goes away when you're lying down, it means that the pressure inside your head is too low.
Thank you. Question here on genetic testing. So the first step is to find out if someone is suitable for Tofersen is to have genetic testing. How does someone access this? What does the process look like?
Well, if you're part of a family with a known mutation, then the best thing to do is to see your GP and get a referral to the local genetics service. So genetic services historically are embedded within the public hospital system, because again, there's no again in Medicare, how Medicare is set up, there's no sustainable way of making genetic counsellor positions financially viable. So they're part of the public hospital system. We have a genetic counsellor as part of our MND clinic at Macquarie, and I understand that others are doing that too, which is fantastic. So for 10 years, we've had genetic counsellors in our clinic, but you need to, if you're clinically normal and there's a family history, you need to know what that mutation is and get an appointment to your local genetics service. And they're fantastic, the genetics clinics, you know, in Canberra, in Hunter, in Brisbane, in Melbourne. You know, regionally it's a little bit more challenging, but you should be able to get access to genetic counselling, which is important. If you're clinically normal, you need to consider all the pluses and minuses about getting a genetic diagnosis.
Absolutely, good advice. Shane is asking, what does definable weakness look like?
Well, it's a little bit like beauty, Shane. You know it when you see it. So to make a diagnosis of motor neurone disease, you have to have a clinical weakness that's focal, that has a clear history of progression, and a combination of upper and lower motor neuron features that are supported by neurophysiology. And you have to have an absence of an alternative cause with extensive investigation. So the diagnosis of motor neuron disease is a positive thing. It's not a diagnosis of exclusion. That's completely wrong. It's often trotted out that it's a diagnosis of exclusion. That's incorrect.
So I actually, for one, have been mistaken on that. So what is it? How do you get diagnosed with MND if it's not the path by exclusion?
You've got to see someone who knows what they're looking at.
Good answer. Preferably someone at Macquarie or someone.
No. We're very fortunate in Australia. We have a very talented fraternity in neurology who are heightened and spend a lot of time working on motor neuron disease. But you've got to get to that person. So, you know, if you have slurred speech, you shouldn't end up in the ear, nose and throat surgeon's office. And if you've got painless evolving weakness in a limb, then you shouldn't be being seen by an orthopedic surgeon or a neurosurgeon. So 40% of my patients have an unnecessary operation before they get to me. And there's an average 12-month delay from symptom onset to diagnosis. So there's still an education piece that we need to do with our general practice colleagues, and we're doing that. So we've created a web tool that enables GPs to work out when they should have an index of suspicion around motor neuron disease. That we just stole it. We stole it from the ALS Association and modified it for Australia. And it's on our website, which is thinkmnd.org. And that enables GPs, if they're worried, to actually have a discussion with me to work out how to get to the diagnosis quickly.
This is the number one issue I hear from the community every day, speeding up diagnosis. So that's fantastic.
It's because the general perception is that this is rare. This is not rare. This is 1 in 200 people. This is not rare by any stretch of the imagination. You know, I currently look after 270 people. There's arguably 750 people in New South Wales, and we need to enable access to specific diagnosis uniformly.
Unfortunately, in Australia, sometimes postcode does dictate healthcare. I've got a question from Ambrose.
It absolutely does. And so it's against the law to discriminate against people on the basis of race, colour, religion, gender, sexual preference. It's against the law. But you can absolutely discriminate against people depending on where they live.
We will see what we can do to try and overcome some of that. Got a question from Ambrose for you. It's quite specific. But Ambrose is 63 in the range for MND development for his SOD1, but is symptoms-free with normal NFL levels. Ambrose is asking, is there any point in having 6 or 12 monthly NFL test?
No.
And is also wondering where he can get Tofersen because Sunshine Coast Hospital might be able to deliver it, or would he be better off travelling to Sydney, or should he call your clinic?
Sunshine can have Anthony Winkle in Sunshine is absolutely perfectly set up, as is Gold Coast, as is Brisbane, as is Wollongong. Multiple sites in Sydney, Melbourne, Adelaide, Perth. This shouldn't be considered elite and site specific. This is a very straightforward therapy. So and measuring neurofilament, like you can't get your hands on Tofersen unless you have a clinical diagnosis of motor neurone disease. So no matter what your neurofilament level is, and neurofilament is not all that it's cracked up to be.
I've got one more question for you, which is back to sporadic. This is a question I've just lost in a question from Rosemary. Do some people with sporadic MND have completely normal genes, or are there always faults?
Well, the way we define sporadic is that there's not a genetic cause. So there's no family history. And then we here at Macquarie, we systematically look for the faulty genes that we know are involved in genetic motor neurone disease. So do we know all the genes? No, we don't. So we know probably in excess of 90% of the genes that cause motor neurone disease, but we still have families, kindreds that I look after where we have an autosomal dominant history from parent to child, but we don't have a candidate gene. So we're doing research that Kelly Williams and Ian Blair do. That's their discovery work, and it leads to insight. Like Ian was seminal in identifying TAR-DBP, which is the gene that encodes for TDP43 and FUS, and Kelly was involved in the identification of ubiquitin too. So this genetic discovery is critical. But my hope is that with IVF and assisted fertility techniques such as pre-implantation genetic testing, we can have babies that don't have these faulty genes. And we already have 10 babies born to our clinic that don't have a faulty gene. So coming back to the question is there a genetic abnormality in sporadic motor neurone disease? By definition, no. That's why it's sporadic.
Dom, we've run out of time. Before we go, I'd just like to ask you, where do you see MND research and breakthroughs going in the next sort of 5 to 10 years? What's on the radar? What's on the horizon? What are you looking forward to? And what should the community be keeping an ear out for?
Well, in June, New South Wales, for the first time globally, made motor neurone disease the disease of notification. So what does that mean? Because just identifying who has motor neurone disease, unless you do something with that information, it's pointless. So we're working on actually what under the hood is going to look like following the notification becoming active in the New South Wales Department of Health. So we need to have an in-depth study. Until proven otherwise, sporadic motor neurone disease is an environmental disease. So if it is environmental, it's potentially preventable. But even if we can't do anything about what's going on in the environment, the cause informs mechanism. And until we actually have mechanistic specific therapies, we're not going to change the face of this disease. There have been more than 200 clinical trials over the last 30 years in motor neurone disease that have failed miserably. And that is just not good enough. And I'm at the, in the last lap of my career, I would like to think that we do a much better job at defining cause. Everyone wants to know why they've got it. But in addition, everyone wants to know, what are you going to do about it? And I firmly believe that we will have our melanoma moment, where we will have a 50-fold increase in survival that is completely determined by mechanism. The infuriating thing at San Diego last year at the International Motor Neurone Disease meeting was that, apart from the work that we presented from Macquarie, and there was some interesting stuff from the Loire Valley and from Turin in northwest Italy, there was almost nothing on sporadic motor neurone disease.
Well, that might be the perfect thing to have you back to talk to us and share your insights as your research develops, because certainly with the bulk of the population having sporadic MND, we need a lot more progress there. So very much looking forward to hearing from you. Dom, really wanted to thank you for joining us today. Thank you for your time. Thank you for being able to explain things so simply for us and connect.
And you didn't have to dump anything that I said. I didn't swear.
There was no swearing. I'm going to tell Jane Simpson. She'll be delighted. Dom, thank you so much. Have a great day. And thank you everyone for joining us today. This webinar will be recorded and put on our website. But otherwise, really appreciate your time today and hope it's been useful. Have a great day, Dom. We'll talk to you soon. Thanks, everyone.